right, good afternoon, everyone. Thank you all for joining us, and thank you to everyone who's introduced themselves on the public chat. Welcome to the Technical Assistance Network for Children's Behavioral Health, Cultural and Linguistic Competence Peer Learning Exchange. The Peer Learning Exchange is a webinar or monthly call with topics focusing on culture, health equity, and disparities in child, youth, and young adult behavioral health. Topics are generated by you, individuals working in, being served by, or partnering with behavioral health organizations and system of care states, communities, tribes, and territories. The TA Network, as it's known, is part of the National Training and Technical Assistance Center for Children's Behavioral Health for the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA. My name is Linda Callejas. I'm an assistant professor at the University of South Florida, and I direct the Cultural and Linguistic Competence team for the TA Network. Today's webinar is titled The AAKOMA Project, Engaging African American Youth and Youth of Color in Addressing Depression and Other Mental Health Needs. We're particularly excited to hold this webinar in recognition of Black Emphasis Month, given our understanding that Black history is generated every day of the year. Today's discussion is intended to explore the work of the AAKOMA Project, which focuses on developing and implementing rigorous, culturally relevant, patient-centered, and community-engaged research and clinical care. It highlights the importance of engaging directly with diverse Black youth and other youth of color and their families and communities to address the mental health disparities they experience. We're very excited to welcome Dr. Alfiee Breland-Noble today as the lead facilitator for this peer exchange. Dr. Alfiee, as she's widely known, is a gifted public speaker, researcher, author, media consultant, and fully licensed psychologist in 2 states and the District of Columbia. She's realized her passion for helping racially diverse young people, including teens, young adults, and those who are young at heart, achieve optimal mental health via research and care for depression, anxiety, and other mental illnesses. Dr. Alfiee has been featured on a variety of media, including radio, podcasts, and national television programs such as A&E TV, PBS NewsHour, and NBC Nightly News with Lester Holt. She also consults frequently with K-12 public and independent schools, community-based organizations, colleges and universities, and nonprofit and professional organizations, including the NCAA, the Big East, and Lucky 8 Television. Dr. Alfiee also consults with the Steve Fund as their senior scientist. Before I turn the mic over to Dr. Alfiee, just a quick reminder that this presentation is being recorded and your lines will remain muted to help eliminate the background noise. So please feel free to use the chat box to type in any questions or comments during the presentation, and we'll work to address these. And we also want to ask that you all stay on following the webinar to take the survey. And now, without further ado, I'd like to turn the time over to Dr. Alfiee Breland-Noble.
Thank you so much, gracias, Dr. Callejas. She's been wonderful to us and has been instrumental in getting us to this point. I also want to thank Tiara with that pretty name I told her for helping us get all set up today. So I talk fast. I'm going to try to not do that today. And I'm also going to try to walk us through all of the slides that we have here. I also want to introduce my research assistant, Ms. Camelia Harb. Camelia is a doctoral student right now at the University of Missouri in St. Louis and getting a PhD in clinical psychology. She's also going to be participating on this call. So the AAKOMA Project is something that I am tremendously proud of and have valued and have really tried to build over the last 22 years. It started at the 1999 American Psychological Association Convention when the then, someone I regard very highly, Surgeon General, Dr. David Satcher, gave a talk and presented his report, his seminal report about culture, race, ethnicity, and mental health. And that really was something for me being fresh out of graduate school. It was just life-changing for me because it was finally someone who was acknowledging that we as people of color, I'm an African-American woman, that we as people of color have mental health needs that really need to be addressed in culturally relevant ways. And that the outgrowth of that was really the AAKOMA project. And so our goal was, I was sitting with a colleague who was a very dear friend, who's a Haitian-American woman, a black Haitian woman, and we were having a conversation after his presentation, and I said to her, we talk about all these treatments and interventions, and people really love to talk about the evidence base. But my question was the evidence base for whom and under what circumstances? And I also said to myself, you know, we can have evidence-based practice, practice-based evidence, but if we can't get people to sit in the chairs, they cannot benefit from the development that we create. So that was really the impetus and the genesis of the AAKOMA project, which was really to take the knowledge and awareness of one marginalized population, African American and black folks. And when I talk about African Americans, I also say black because I'm very cognizant of the fact that I have Caribbean black brothers and sisters, African immigrant black brothers and sisters, as well as black Latino brothers and sisters. And so when we talk about black, I will say black and African American because I want to try to represent the fullness of that African diaspora. So our goal is to really try to address those depression needs and the mental health needs of African American black youth and youth of color. And because I'm a scientist, I have a master's degree from the Duke School of Medicine in clinical trials, essentially. It's a clinical research degree. The way that we do it, it's really important to me that it's rigorous. Are people not hearing me? I think somebody's asking about audio. I think we're okay. So we're going to take you through some of these slides and, you know, hopefully leave enough time for questions. All right, so this is just a picture that shows lots of the different kinds of work that we do. You can see that there are all kinds of people in these pictures. And that there are young people represented at the table. There are people of different ages. And what's super important to me is that there are people of different cultural backgrounds. Because one of the things that's really important to us with AAKOMA is to acknowledge that not everybody who's going to be able to help a child of color, an African-American child, is going to look like them. But what we need is for people to understand like them, i.e., cultural competence. So you don't have to come from where I come from, but what's super important is that we teach people the ways to engage our young people so that they feel seen, heard, less marginalized, and centered. And what we're going to share with you in this talk is some of the ways in which we do that. All right, so through AAKOMA, what's really important to us is community-based participatory methodology. And why that's important is because we want to go to the experts. The experts are the people with lived experience, right? And I'm really preaching to the choir because you all already know this. But what's important to us in particular is to really center the knowledge that is already possessed by people in the community about their experiences. And so there's a colleague I have who's out of California. Everybody knows her in the community-based participatory research space. She works with Ken Wells. Her name is Ms. Jones. And Ms. Jones says, Dr. Breland-Noble, Dr. Alfiee may have a PhD from the academy, but she has a PhD from the streets, and that's how she talks about it. And so, you know, it really is this idea that there is a wealth of knowledge in communities that we have to be able to tap in order to make interventions that are going to benefit people and that people are going to want to utilize. All right, so when we talk about the mental health needs of African Americans, black folks, people of color, there are a couple different areas where these mental health concerns, exist, where the disparities exist, right? One of the places that they are less likely to exist is in who has mental illness. So when we look at the question specifically, SAMHSA data tells us that somewhere around 10% of African American, Latinx, and white youth, that's the data that is most readily available. I recognize that it does not address the needs of Asian American youth, Native American youth, Arab youth, or people who are marginalized around their religion, Muslim youth. I recognize that. And so the data that we know the most of is African American Latinx, black African American Latinx, and white youth. Those youth do not demonstrate statistically significant differences for the most part in who has depression. A little bit in terms of who has anxiety, but all of these kids are hovering somewhere around 8 to 10% of depression and about a quarter for anxiety disorders. So where are the disparities? It is in these four areas that you see here. Decreased access and less availability of services. I would also suggest that less likelihood that they're going to receive culturally relevant services, right? So in terms of linguistic competence, which is the focus of the series, the availability of providers who speak the same language as many of our young people of color, they're less likely to have access to that. There are issues around cost and insurance, but we also have to recognize African Americans and blacks come in all socioeconomic strata. So even when black people have insurance, even when they have money to pay, it is less likely that we are going to utilize care. And there are many reasons for that. So as you see in bullet 2, it's less likely that we're going to receive the required services that we need. Bullet 3, many more experiences with poor quality of care. I've talked to many. I see patients once a week. Often the conversations have to do with other people that my patients have gone to see where they have not felt heard or seen or understood with the needs that they bring to the table. And then finally, something I'm super passionate about, the underrepresentation of black people in research. This is a problem, and part of our work, as you will see from the slides that follow, is to try to address that concern. All right. So in terms of, I shared a little bit of statistics with you before, but as you can see from this slide, I'm not going to read it, the point is that for all adolescents, there is underutilization of mental health care. But for young people of color, there is far less representation in terms of who gets into care and who stays in care. So as you can see from the bullets at the bottom, our young people, the very last one, are far more likely to utilize emergency services, go to the ER, than they are to use specialty mental health care, including inpatient services for psychiatric or mental health or behavioral health concerns, right? And we also know, culturally speaking, which I think I have a slide about later, for certain groups, African Americans and Latinx populations in particular, there's a huge faith component. And so sometimes people are going to go toward the faith community for behavioral health concerns before they will come into the mental health specialty behavioral health space. All right. When we talk about ways to address these issues, right, I've shared a little bit of background, how did we get here? What we're talking about in terms of trying to address these issues is to think through how can we improve how care is provided as a means of shrinking that gap between people who need care and the actual receipt of behavioral health care. So what we want to try to do is to examine the current levels of knowledge and attitudes from African American black youth, other youth of color, related to mental health. As I said earlier, they are the experts in their lived experience. And so what we want to do is access their knowledge and then utilize that knowledge to build a better model. That's the goal. We want to build a better research model, and we want to build a better clinical care model. Right? And so what we want to do to reduce barriers to care and research involvement has to do with these things that you see at the bottom. We want to be culturally competent. We want to identify, I have this saying that I use all the time, there are multiple ways of knowing. There is never just one way of knowing. So we want to develop innovation. We want to develop alternatives for treatments so that we can improve the cultural relevance, the accessibility, and the availability of treatments. We want to make sure that people understand what we're talking about in a language that resonates with them when we talk about mental health and mental illness. Everybody does not say depression, and I know from 20 plus years of working with young people, more often than not, they're not using the word depression to describe what they're feeling. They're using other words. And so we have to be trained to understand what their language is to be able to help them. And then finally, we want to engage in collaborative mechanisms to ensure that what we're building fits the population that we want to work with. And you can see some of those approaches on this slide. All right. So these are just some definitions. I'll leave them up for a second. Many of you are probably already familiar, but this is the kind of work that we engage in with the populations of folks that we serve. Patient-centered outcomes research is our focus, comparative effectiveness research, and we utilize CVPR, community-based participatory methods. All right. PCORI, we want to acknowledge because PCORI has funded almost all of the work that we're going to talk about in this presentation, so I just want to acknowledge them. And if you need more information about PCORI, because we don't have a lot of time, please do look them up at pcori.org. All right, so I'm going to turn it over to my lovely research assistant, Camelia, who was instrumental in this work, and she'll go forward.
Hi, everyone. Thank you for attending and joining us on this webinar, and thank you, Dr. Alfiee and Dr. Callejas for the intro. So, as Dr. Alfiee has said before, the objectives of our research have been very synonymous between our projects, with the underlying goal of not only disseminating what comparative effectiveness research is, but also to create a network, a community network, in which we pass on the skills and kind of foster this sense of knowledge around what community engaged research looks like. So the objectives of our research have been threefold, which are we wish for our participants and our partners to understand that the details, what the details of comparative effectiveness research and patient-centered outcomes research are. So from now on, I'm going to refer to them as CER and PCOR, much easier on the tongue, because we want them to understand what the bare bones of these concepts are and give them the skills that they need if they ever want to pursue these fields of research in the future. A second objective is for participants to learn about general knowledge and attitudes of around use of color surrounding the field of mental health treatment and research, because they are aware of what the situation is within their own community. So by giving them further knowledge and understanding where their awareness levels might be, it helps us to further promote our goals with the community that we are interested in working with. And finally, we want participants and partners to understand and be able to apply the tenets of CER and PCOR in similar communities, whether this be of their own volition or in partnership with other projects or other PIs, in order to generally increase mental health research engagement and awareness. So as Dr. Alfiee had intimated before, PCORI has funded a series of our projects with similar participants within Black faith communities. And the first of these projects was the Engagement Award Project, which was entitled Engaging Black Faith Communities to Address Mental Health Disparities via Curriculum Development. So the goals of this funded project were also threefold, which was, as I've stated before, to build a core network of African American youth patients, leaders, caregivers, parents, community members, or other invested stakeholders in developing the skills of PCOR and community-based participants research. We wanted to evaluate and identify factors that might promote or hinder faith-based mental health promotion, as well as what would we need to instill, or what the current level of knowledge around research was within the community in order to foster and support training in PCOR and CER. And the third goal was to use the information that we gained from this process to develop a patient and stakeholder-focused curriculum that was built around these tenets for the purpose of promoting African American youth mental health. So this curriculum, I know it's not on the slide, but I wanted to describe a little more about what it was for. The curriculum was intended to be used as a kind of base in future initiatives that may want to have been done within the community, in order to provide a kind of manual of sorts for how similar partners, similar community groups could do this kind of work within similar populations of color for similar purposes. So this was built around the information that we gathered over this 2-year project, and it was turned into a formal curriculum draft that was submitted to PCORI as draft manual that could be used for future similar initiatives. So over the process of, this was a 2-year project, we managed to engage 15 faith communities in the DC area. This included parts of Northern Virginia, District of Columbia, and some parts of Maryland, as well as different communities in North Carolina. This was in the Raleigh, Durham, Charlotte, North Carolina areas. Throughout these 15 faith communities, we recruited a total of 203 individuals, these were both youth and adults, to participate in survey completion and group discussions, with a total of about 17 focus groups completed. An additional 38 individuals completed something called the IHPCC, which stands for the International Health capacity promotion check. Sorry, it's an interesting name. But the purpose of it was it guides assessment. It assesses the level of awareness around health promotion practices and also addresses the capacity of a given population to disseminate knowledge around this and their own ability to promote mental health awareness or health awareness in general. So like I said before, this drafted curriculum included an introduction, a summary, a session format, potential evaluation procedures, and the module content around what developing research within the community could look like. And this research is promoted and by a partnership between community members as well as research practitioners. So of these 203, I'm reading the questions as we go. So it's an international health promotion capacity checklist for, I think that's Diamond asked, yes. Sorry, I'm reading the questions as they pop up. And then I just saw another question for, will the curriculum be available to participants? Dr. Alfiee responding to your question right now. So of the 203 participants, about 160 of them were adults, and there were 40 youth as well. These youth were between the ages of 13 and 17, and adults were 18 and up. And I think the oldest participant we collected from we had seniors as well, so it was up to people in their 80s as well. Like I said before, these were collected from Charlotte, Raleigh-Durham areas of North Carolina, as well as the Washington, D.C. area. We checked for basic demographic breakdowns, which included things like gender, age, religious affiliation, education level, and income. The focus groups that we conducted were audio recorded, and these were sent to a transcription agency, and they were transcribed, and then our core team analyzed them for qualitative themes. I will talk about a few of them in just a few moments. And the standardized surveys also gave us additional information around where the community's level of understanding of CER and PCOR were, and we also were interested in looking at what their opinions around mental health treatment and engagement would be, things like their awareness of what mental health meant, as well as potential level of stigma towards seeking help and engaging in mental health treatment. So this is just a quick breakdown of what the demographics looked like for the sample that we used. And it was very important to collect on demographics because a lot of times when we look at the research that includes participants of color, we're focusing on specific subsets of that population. So when somebody says an African American population, oftentimes they think, oh, we're about to talk about racism and disadvantaged groups. But it's very important not only for academics to know this, but also for participants to know that this is a wide range of research, that research affects all subsets of the population. So we wanted them to be able to see that it wasn't just everyone who was making a certain amount, was in a certain income bracket, that it spread throughout the income bracket, and that we had both men and women involved in this, and that education level of everyone was all over the place. So you're not only focusing on one specific group of people. So in general, the biggest takeaway that we wanted to look at was what was their understanding of the core concepts that we were looking at. So for the most part, adults indicated they had a good understanding about how PCOR and how CER worked, which was great for us because it meant that there was a base there to build off of in promoting these concepts within the community. For the youth, we had collected data from 40 youth participants, and also we wanted to just see where they were. Most of them were high school students, however. And with the same point, they also had a good understanding of how PCOR and how CER worked, which again was a good sign for us because it meant that there was a basis upon which we could promote the understandings of these concepts. And as I said before, we did focus groups that we had coded, and we compiled a list of main themes that we kept finding throughout them. And some of these themes included mental health as a source of stigma, using faith or the Word of God as a means of healing, the need for cultural competency, which is something that Dr. Alfiee talked about before, validating the experiences of not only acknowledging that you had a mental health problem or knew someone who had a mental health illness, but validating that it was okay to talk about it in public or in a given community, as well as this went hand in hand with the acceptance and acknowledgement of mental illness. So I'm not going to read the quotes that we had pulled, but as just a general idea, the biggest ones that we found were the idea of mental health having been a source of stigma. Maybe not necessarily in the present moment for these individuals, but that they had had specific experiences where they did not feel like it was culturally okay to talk about these things. So that was one big takeaway that we found across focus group transcripts. Another one was, again, as Dr. Alfiee was talking about, the need for cultural competency and culturally relevant services. Many of the participants who were in our focus group said, even if I have this problem, I can't always go talk to somebody because they're not going to understand where I'm coming from as an African-American woman, as a Black man. So it was something that participants, that people in the community are aware of. It's not just something that is highlighted by professionals and academics. And finally, a third one was this big idea of needing to accept and acknowledge that mental illness does exist, and this desire to shift it from being a concept that may be taboo within the community as one that could actually help facilitate discussion and growth within that community. And yes, so now I'm going to pass it back to Dr. Alfiee to talk about another PCORI-funded grant that we worked on.
Okay, thanks, Camelia. So we want to try to leave 10 minutes at the end for everyone to ask questions. Please do, I want to encourage folks to put questions in that chat box because that can streamline the process for us some. Camelia did an excellent job of really talking about what we learn from folks. And you can hear the excitement in my voice. I get so excited when I talk about this because for our communities of color, African Americans, Latinos, Arab folks, Native American folks, Asian American folks, it is so rare that we have the opportunity to really speak our lived experience. And so what you're seeing in the work that we're doing is people talking about their lived experience. And that's why the mixed methods approach was so important, and that was why it was so important to us to validate the experience and to really make sure that the folks we were working with were front and center at the table, in many cases at the head of the table. So you can see the benefits of that kind of work. The work, it has great yields, and what you can't see is how much effort went into getting us to that point, right? So to be able to have a study where we were able to recruit over an 8-9 month period 200 African Americans, to me that is phenomenal, and that's one of the things I'm super proud of. So I'm going to take you a little bit through some of what we did on another one of our projects, and as you can see, there's a theme. Some of the themes, there are a couple themes. One is that we're working with Black folks across the socioeconomic spectrum. We're working with Black folks who are in faith communities. We're also working with Black folks who aren't necessarily working in faith communities, but who are community members nonetheless. And so what you're going to see here is a pipeline project that was a little bit more broad, and the focus of this project was to move us from an idea, a concept that was built collaboratively between the academics and our community partners to an actual submission of a full, I think it was a $2 million grant at the end of the project. And that was the purpose of these pipeline projects, is this collaborative approach to submitting fundable grants. All right. So with that, you can see the name. It's really long. I'm not going to read it. But the whole point was twofold, to get us to that grant, but also to build research capacity. Once again, PCORI is about building capacity, so that even after folks stopped working with us, with the AAKOMA project, which we hope they would never leave us, but if once they did, they have knowledge, a new set of awareness, and a new set of skills to allow them to engage in both research and helping to build community capacity for other aspects of the treatment of mental health in their own communities, right? And so one of the things I always said to folks is, I want, when you leave me and other researchers want to come into your space and say, oh, we want to work with the community, you are now equipped to vet them properly. You can ask questions. How is this budget going to be structured? What portion of the budget will the community have control of? What portion do you have control of? Are you going to train us in research ethics so that we can have IRB certificates so we can do this research along with you? And these are all things that we did and integrated into our work as a means of demonstrating to folks, this is really how you should be treated when you're working on these research projects. So you don't allow people to marginalize you. You require that you be centered. And that was really, empowerment was something that we were all about. So I've shared a little bit about the goals of the Pipeline to Proposal project. Strengthening relationships was key. Building capacity was key. You have to do that through actually physically being present and engaging folks. And then you want to leave something behind. You want to leave some portion of the infrastructure to the extent that you're able to ensure that the work lives on even after you're gone. And all of these things, I think, translate, right? I have a saying, a rising tide lifts all boats. And one of my friends kindly pulled me to the side and said, but not at the same time. That's true. But I still stick with this idea, if you empower people, you give them the capacity to be able to do more even after you're gone. So those were really some of our goals. So you can see the tiers of the project. At the time, the way this project was structured is there were 3 tiers. Now there are just 2. The focus must be on comparative effectiveness research. But the goal is, I likened it to dating, for better or for worse. It might be a bad analogy. But when you're dating, you start out, you don't know each other. That's tier 1. Tier 2, you've made a connection, you've made a commitment to each other. Tier 3, now you're planning for what is our life together going to be like. And then tier 4, at the end of tier 3, you're submitting that grant. Hopefully it gets funded, and you will continue to work together, whether you're funded by PCORI or a different funder altogether. So the goal is for you to have capacity as a community member, and for us as academics to learn how to effectively build capacity, develop and maintain relationships with racially diverse communities, given that we're coming from our academic space. All right, so within our pipeline award, we'll go quickly through this. We were able to empower and create space to empower our partners to form their own subcommittees, right? And so we had an outreach and communication subcommittee. We had a recruitment, right? Recruitment not of patients, because we weren't at that stage, but additional partners. We had a hospitality committee for our meetings. The teenagers had to be present, so we had an adolescent focus committee, and then we had administrative pieces. And what I want to say is the structure of this was one such that a lot of the work that happened because the community members led the work. It wasn't just us from the academy saying this is what needs to happen. They were instrumental in this. And a good example of that is the question that we ended up choosing, as well as we had a website. I think it's still active, Partners in Faith for Youth Mental Health. We had lots of different sort of giveaways that we could leave with people. The giveaways were actually the idea of the community partners. And so one of the partners, I remember it was a sister of a certain age, she's a grandmother, and she said to us, we need to have a way to explain to people succinctly what it is that we're doing. So they came up with this idea of bookmarks. And I'm actually looking at some of those bookmarks in my office right now, and we still give those bookmarks away to share with people. This is something that came from the community. We didn't make that up. Camelia and I didn't come up with that idea. They did. And so through the pipeline process, we were able to expand what started as just the academic folks. I have an academic appointment at Georgetown, and then a subset of faith community folks, and our team began to expand. And so our team grew to include MindRight, which is a wonderful text-based service to assist youth with traumatic stress. It's a fantastic app. David Street, who is a leader in our local area who works with African-American men, which was a big focus, both because PCORI told us it needed to be and because our community partners were adamant that we figure out how to bring young men to the table, because African-American men are often a neglected subset of the black population. And then we also have representatives from the Arlington, which is a Northern Virginia county of behavioral health. All right, so what do? We developed a question, and you can see that there are multiple parts to the question. So I do not identify myself as a trauma expert. I am an expert in the treatment and treatment engagement of adolescent depression and anxiety, particularly for African-American and black youth. So with the team's focus, with our community partners, they wanted us to focus on trauma, because some of the communities that they came from, and we know trauma affects everybody, but for some of these communities, community violence was a huge thing. And so in this case, the group decided, let's focus on depression and anxiety that are an outgrowth of exposure to trauma. And we said, absolutely, let's go right ahead and do that. And so the whole idea is just to say that in the context of developing the comparative effectiveness research question, we really relied on the partners to help shape that question so that it would become something that they valued and that they could co-own, which really speaks to and fosters commitment and engagement. All right. So in March of a year ago, we submitted a letter of intent. Remember, I talked about the tiers, and the final goal is to submit a grant, a large grant. And we submitted a grant under the Addressing Disparities portfolio for PCORI. So as you can see down at the bottom left-hand corner, it didn't print very well, but that's the logo that the community partners and I came up with, Camelia and I came up with. And you can see on the right, there's our AAKOMA project logo, which has been our logo for probably the better part of 15 years. You see the two hearts. If you notice, the partners wanted those hearts integrated into what we came up with for our logo as a means of saying we're doing this together. And so you can see Mind Right represented their logo. Please do find them online. And then PEN DMV, which is the local organization that really focuses heavily on African American males' needs. All right, so Camelia, is this you looking at the data?
Yes.
All right, go right ahead.
Thank you. So just as a final point, is why this type of research is important and why engaging youth is also extremely important, particularly youth of color in this discussion. Is as we were saying before, so much research focuses on specific subsets of the population that when we submit to journals, when we read journals, we see the sample that is described and kind of there's like an automatic association made with what we're going to be talking about or what that study is going to be talking about. So when we get to engage the perspectives of other people from the population, we learn so much more. So taking some of the data that we had collected from the Engagement Award project, we looked at if we are trying to engage youth of color in the discussion about promoting mental health for youth of color, coming full circle, then what do they know about mental health? And how do they feel about mental health? We know just as in general, current generations are much more open to the discussion of mental health. It's less stigmatized, not to say that it's completely destigmatized, but there is less stigma around publicly speaking out about these issues. So what we looked at were collecting from some of the surveys that we had collected included this scale called the Social Stigma for Receiving Psychological Help scale, which essentially asks this user to rank on a scale from strongly disagree to strongly agree how they feel about the idea of approaching somebody for help and what they would think about somebody else going in and seeking help for a mental illness. The level of familiarity measure also has participants either agree or disagree to a list of statements that assesses their familiarity with different levels of closeness to mental health. So this could be something like, I know what mental health is, or I know what depression is. I've seen a TV character with a mental problem, or I have somebody in my family who has a mental health issue. And that kind of creates a ranking of how close, quote unquote, close you are to the concept of mental illness. And we were interested in looking at what were the relationships between associated levels of stigma as well as level of familiarity with mental health, and does this correspond at all to level of understanding of what CER and PCOR are, with the goal of maybe we can try to establish not a causality, but at least try to say that because youth are much more open to these ideas, they are the perfect target for training in this field for future initiatives that could help spread awareness. So on the whole, what we saw was that the youth of our sample did not associate receiving professional psychological help with greater social stigma. They also disagreed with statements that seeking help should be stigmatized. So they were much more of the mind that seeking help is something that should happen. They also indicated that an average of 4 experiences, which is a weird way to phrase it, but it meant that they were endorsing various different statements that on average about 4 different statements of how familiar they were with mental health, whether this be they were aware of it or they actually knew somebody with it. And on average, they experienced this moderate level of intimate contact, which meant that for many of them, they knew somebody who did have a mental health problem. Combining this with what we had collected before about their knowledge of CER and P-core, we kind of drew the conclusions that the youth sample did not assist. So, as I was saying, apologies, everyone. So the youth sample did not associate help seeking with stigma, but they were aware that people who did seek professional help may come with the association of social stigma. So they had that awareness, so they themselves would not personally endorse stigma for seeking mental health, whether for themselves or somebody that they knew. Research has also demonstrated that when individuals are less likely to endorse negative stereotypes of mental illness, or they're also more likely to know somebody who maybe has mental illness, or they're more intimate with the knowledge and awareness of what mental health is. Based on these results, we came to this conclusion that youth who had more contact with individuals with severe mental illness, or at least awareness of what mental health was, would be less likely to endorse those negative stereotypes of mental illness, and it would be less likely to stigmatize mental illness and stigmatize receiving help for mental illness. So all in all, this is very comforting to know. It's a good takeaway because it shows that this is a potential group that we can engage to better promote mental health literacy as well as mental health engagement, whether that be in similar research or in other treatment studies. I'm going to pass it back to Dr. Alfiee just for the wrap-up.
Okay, so one of the things I want to say is we've shared with you two different projects. You can see that there's a thread that runs through both of those projects. And just anecdotally, I'll share that, while our focus was, in this case, building capacity for research, whether it was for the development of the curriculum, which we completed, or it was for this project, which was to allow us to develop a proposal. And I want to tell you quickly about what that proposal was about so you have an idea, so we can sort of close the chapter on what each of these projects accomplished. But the goal really was to ensure that we understood from the perspective of the patient population, the stakeholders, the caregivers, the community members, the advocates that we wanted to reach, what were the most important things to them that they felt were going to be the catalyst to get young people of color engaged in the mental health care process primarily, but also in the research process. And I think a part of it really has to do with making sure that you build upon what you hear from people. So our process was iterative. So every time we would come to the community members with questions, we would take that feedback. Camelia and I would get together. We would figure out how do we take what we've heard, funnel that back to our community members, while at the same time, right, we were doing a dance. Because the language of the community is not the language of the academy, right? And many of you already know this. And so how do we take what we've heard and translate that, so to speak, so that it is something that resonates with everybody, really sort of teaching to the middle. And so that was one of our takeaways, was being able to translate it. And so in terms of the curriculum, when we work with folks with the curriculum, we had to translate things like, thinking back to the Engagement Award, the curriculum that we developed was focused on faith communities. For those folks who know black faith communities, most are Protestant. I happen to be a black Catholic, so my experience is slightly different. But for black Protestant faith communities, there's a hierarchy, right? That's the reality. And the hierarchy often, not always, includes ministries, right? Ministries are basically like little committees. So we had to do things like, say, we might want to form a research committee. That was how we would describe building capacity for community members to lead and engage in their own research in the academy, right, building a research committee. But you don't build research committees in black faith communities. You have research ministries. And so it's that ability to be able to do the crosswalk using the same concept and make the language fit for different populations. And that, for me, was a big takeaway. Another big takeaway was my intent was not to recruit young people to come into treatment or to seek psychotherapy or mental health care. But there were multiple occasions where just through the process of having focus groups, talking with young people, including young adults, that would ultimately result in young people in the groups seeking care. All right, and so there's something about this parallel process of when you engage people, I think, in effective and careful and thoughtful and culturally relevant and culturally centered ways, there are so many more benefits beyond just that project that you're trying to work on. So finally, that's references. So what we want to say in closing is just that it was really important for us to think about going forward, what are some of the ways in which we can extend the work that we've done into other arenas or just build upon it, right? And so you can see here a couple of different ideas that we came up with. What are some of the, I'll skip through a couple, what are some of the culturally relevant predictors of treatment effectiveness? For me, a big example of that is what are the culturally relevant things that are going to keep a young person in treatment long enough to get the benefit of the treatments that exist. That is so important to me because so often we get one opportunity or two opportunities with our African American and other families of color to reach them, right? But what are the things that are going to keep them in for these doses? And we know with manualized treatments, the dose, air quotes, is sometimes 10 to 12 sessions. My wish is that we would be able to keep families long enough for them to get that dose of whatever that intervention is. And then the second thing is the last bullet. How do we tailor interventions, not just for cultural adaptation, although that is important, but to the specific and unique needs of the people we want to reach? How do we make sure that we reach the people we want to reach in a way that is meaningful to them, right? And in our case, because it was PCORI funded, their language, their terminology is patient. So I have to say our young people did not like. They said, don't call me a patient. And so these are some of the things that, some of the big takeaways for us. And what we want to do is be able to extend the work that we did. And I'll tell you quickly, and then I'll stop, what the project was that we ended up submitting. And we actually got a really good score on our initial submission. We were in the bottom, or I should say top. You know how the scoring is so odd. We were in the top, I think, 35, 40% of scores. So we weren't funded because it's a tight funding cycle, but for that to be a first submission, we were really happy with it. So the project was to do a CER study looking at the effectiveness of reducing symptoms of depression and anxiety over a 10 to 12-week period. I can't remember exact number of weeks, where we were comparing the Mind Right intervention, which is a mobile-based intervention, it's all texting, to trauma-informed cognitive behavioral therapy offered in the community. Those were our two comparators. And what we wanted to see is which intervention was going to keep our young people in longer and which one was going to be more effective for reducing the symptoms of depression and anxiety in trauma-exposed young people. And so the final thing I want to say is that, this is thoroughly rewarding work, but it is also thoroughly engaging work that requires a lot of nights and weekends. I'm a mother. I have a tween and a teen. I'm also married. So, it takes a lot, but the rewards are great. And with that, what I want to do is move us to the final slide where you have all of our contact information. And I see 2 questions, so I guess I'll just go ahead and start with the questions. Or Linda, would you like to, do you want to lead that part or you want me to just go to the questions because I can see them?
Oh, you can go right ahead.
All right. So one question is from Serena Wilson. I hope I'm pronouncing your name correctly. And she asked, what are some of the implications of the research for those of us who serve at-risk and incarcerated youth? It's a great question. I think the big takeaway, which is something you're probably already doing, is talking to these youth about what's important to them, understanding from their perspective what is it that they need to feel heard, to feel seen, because I think if you can make them feel seen and heard, it is much more likely you're going to get those young people to get in somebody's chair to get the care that they need. That's one takeaway. I think another is that there are opportunities to form the same kinds of partnerships that we did with young people in those situations. What would stop somebody from writing a PCORI, one of these grants, to go into working with youth who are incarcerated or who are at risk? Why wouldn't you be able to do that? Like, that seems like a really important way to be able to understand what these young people's needs and wishes are, and then to develop interventions that directly meet their unique needs. So that's how I would answer that question. I see a second question from, I know I'm not going to say it right, Ciaria Miller, and you're asking about Teen Court program. I'm very familiar with Teen Court. We actually wrote an article on Teen Court about 6 or 7 years ago with another one of my graduate students. And the question is, you're focusing on youth who are first-time offenders and girls empowered, a mentoring group for young girls. And there are a lot of youth who don't want to talk about mental health, and they do think the conversation is weird. So thinking through how would you engage youth and their families when it's an uncomfortable or a taboo topic. So some of the things that we tried is you want to develop partnerships. And the partnerships that you develop are with people with lived experience. So, for example, when we were on NBC Nightly News, it's like a 3 or 4 minute clip. The person I was on the news show with, it aired like it was in May of 2018. The person I was on the show with is the mother of a young man who died by suicide. She and I have been working together. She worked on both of the projects that we shared with you. She lives in North Carolina. We met when I was a faculty member at Duke in the Department of Psychiatry. And through all these years, we have continued to work together. Part of the benefit of me having her is because I can stand up and I'm Dr. Alfiee, and I can say, I used to wear a white coat when I was at Duke, and I would give presentations. And, at some point, I started to sound like the teacher from Charlie Brown, right? Well, want people to stop listening, especially the teenagers. But when Kathy stands up, you got to watch the clip. When Kathy stands up, she's this beautiful, deep Southern drawl. She's so full of energy and life and light. When she stands up and talks about what her experience was, that grabs black folks' attention. That grabs Latino families' attention. That grabs Asian American families' attention, because what she's talking about is a universal experience of, I saw these symptoms, but I had no idea what they were. And this is not an uneducated woman. This woman now has 2 master's degrees and she's a retired teacher and school counselor. And so she didn't know what she was looking at when she was looking at her son. And so having somebody share their story often, or you sharing that person's story, often can open the doors and open the eyes of families where they may not have wanted to talk about it before. So I'm very much an advocate for, pull out a smartphone and show the family a clip. It doesn't have to be my clip. It can be anybody who's talking about this. There are lots of young folks, millennials, who've made movies. I can think of at least 3 mini documentaries that young people of color have made on this issue of the taboo of mental illness in the black community. For the teenagers, not all black teens like rap. I totally understand that. But what I find is that when I can bring those celebrity or pop culture references to the center in my discussion, that grabs them. So showing them Kendrick Lamar talking about having thoughts of suicide, that opens these young people's eyes. They think if someone like that can think that, then, it's certainly probably okay that I've had this same thought and I'm not alone. So those are some of the ways in which we've tried to encourage people to talk about some of these issues when it really is, as you said, a very taboo topic. So I'm just wondering if there are any other questions. We have about 5 minutes left. I see somebody typing. I'm just going to wait a second. Okay. I see typing. I'm going to hold on and see if I see some questions pop up. No. So one person asked if we resubmitted the grant yet. No, because we just got it back, I think, maybe November, December, we're in the process of rewriting the grant. And the documentaries, I don't. But what I will do is I will try to get those documentaries to Tiara, and Tiara can share them when she shares the other information. And so there's another question about us noticing differences in which youth are comfortable discussing their mental health concerns. No, I think for me, one of the things is, and I see your question, Erica, I'm going to come to that too. I think for me, one of the things in terms of, I don't really know that there's a way to distinguish the ones who are open versus not. I think often the issue is the person they're talking to, because part of what grabs the young people's attention, I think, is authenticity. And if you're an authentic person, again, I will say this, I don't think anybody is concerned about race. A lot of our young people will say, I don't care what they look like, I just need them to hear me. And so often I think people don't try to hear what I'm saying. They don't try to value where I'm coming from. They don't try to relate. And that's why I don't want to talk to them. So I think the issue is really more, I feel like if you're authentic with a young person, if you talk about what your experiences have been, I'm not saying you have to disclose everything about your life. But what I find is that when I share things with young people, for example, something I haven't shared is that I have struggled with anxiety at different points in my life, and it's still something that I work on. When I say that, you can visibly see the kids sort of breathe out. They're like, oh, okay, so, and then I'll describe what the experience of anxiety feels like for me, right? Now I'll talk about like a whirling dervish, or I was doing an interview last night, and I talked about if people remember the fidget spinners. I said, that's what it feels like when you have anxiety. It feels like you wake up in the morning and that fidget spinner is going 100 miles an hour. And so when I say those kinds of things, I think it allows young people to relax just enough that they feel like they can open up. So I think it's us. I think it's less about the young people's characteristics and really much more about us. So I hope that answers the question. So one other person asked, I see a couple questions, but I'm going to try to go through them one at a time. Some of what I noticed is, one question is about working with a mother of two. She's had her own experiences with trauma. And how can we engage a parent in that situation, and she is definitely not alone, in wanting to seek treatment herself. And I think that issue, it comes back to the same thing. It is sharing with her that she's not alone, sharing with her that there are other people who share that experience. Because so often, I think for African Americans and other people of color in different communities, there's this idea that they're the only ones who've ever been through it. And what we do when we share with people other folks' experiences is we normalize this, right? So in normalizing it, we teach people it's okay to feel like you feel. You're not the only person who feels like that. I have experienced that. This person on television has experienced that. That person on the radio has experienced that. And what we want is for people to not feel like there needs to be shame associated with their experience. So I teach people a couple things. One thing I say to teenagers a lot when we talk about the experiences of racial trauma, I'm just going to use that as an example. Even my kids, what I say to them, this is a way of sort of giving people a little bit of relief. So at the same time, it's almost like I'm doing therapy, but I'm not, because a lot of the young people I talk to, they're not my patients. But I will say to them, they'll describe experiences with racism. And they will say, well, they did that because I'm black. And I will say to them, no, sweetheart, it's not because you're black. It is because that other person is racist or sexist or homophobic, that type of thing. And the idea is we need to take the stigma off of the person who is experiencing the trauma, who is the recipient, who is the victim, and we need to put the responsibility on the person who is the perpetrator. So people are not, I'm thinking of my daughter, people didn't give you a bad grade on that paper because it was an English paper and it was subjective because you're black. They gave you that grade because of their own implicit bias. And sometimes giving the person the freedom to understand that they're not alone and to understand that the point of care is not to fix you. The point of care is to understand you so that you can then get some tools to be better. So I'm going to stop with, hope that answers the question. I see a couple other questions, but I think I'm going to let Camelia jump in and answer one of a couple of the comments about spirituality and mental health. You want to go ahead, Camelia?
Oh, yeah, sure. Great. Thank you. So I'm reading the questions as they pop up, and I think I'm jumping around a little bit, but I've seen a couple people say, how do you do that crossover between when you're involved with faith communities, or if you are a spiritual person and a therapist, or if your client or your participant or the person you're interacting with is spiritual, and maybe faith is how they would want to heal or is what they turn to first. One of the biggest takeaways that we got from doing all of these focus groups, and then when we were coding these transcripts, we came up with this phrase that we felt really kind of embodied what people were saying, was this idea of transparency as testimony. So for people who do go to church, sharing the experiences or talking about your experiences is an uplifting thing, making a confessional as an example of what we're talking about. There is validity to be gained in sharing experiences, and I know that Dr. Alfiee was saying that when you're able to make your own connection with the person you're speaking to, and it kind of lowers those barriers that they may have built up around them for why they don't want to share. But there is so much to be gained in kind of promoting this environment, or this, can't think of the word I'm trying to, atmosphere, that's what I'm trying to look for. This atmosphere of openness around the topics. It's not something that's done overnight or easily, but in sharing experiences and bringing people together into a safe space where you can share experiences, there is a lot to be said by that. And it's validating not only in giving credence to your own experience, but even if you don't want to share, knowing that other people go through what you have gone through in itself is healing. So I just wanted to throw in that bit for people who have been asking questions about how to kind of tie in spirituality and mental health treatment. And a lot of people, I know I saw someone was saying in St. Louis that you have pastors from the pulpit kind of talk about mental health. And it is a great point of engagement if you get, especially if it's an individual within the community that is recognized as being a leader, if you have their support, sometimes those are the people that these people will turn to in times of need. So it's always a great opportunity to create partnerships with these naturally chosen leaders of a community as a way of building bridges between professionals and clients, or just individuals within the community.
So I wanted to, there's a question from Diamond, I think I'm saying it right, I'm sorry if I'm saying it right, Diamond Walker, asking about being a provider as well as coming from a spiritual background. And I'm interpreting the question to mean that sometimes people with families, we can sometimes work with families who are, okay, I see the other question too about the curriculum. The curriculum is not a part of the grant resubmission. We kept that separate, but that's a great question. But what I will say, let me say this real quick. What I will say about that is that all of the mechanisms that we wrote into the curriculum, actually, I take that back. We did include the curriculum in. It wasn't a focus of the study, but we used that to articulate our methods and mechanisms for how we were going to engage partners throughout the process of recruiting for this particular study. So, yes, so it was going to inform our community engagement, but we did not include it as a variable that we were going to study. So that's a great question. But going back to this idea of being a provider and working with families that have a real stronghold on religion, what I find is that if, we're trained, now I'm going to be honest about my own training. When I was trained 20 years ago, we were trained to keep the psychology separate from the spirituality, and that never the twain shall meet. And what I find is that being an African-American woman, I can't do that, because if I do that, then I come across as inauthentic with the families that I work with, whether it's part of my research work, and Camelia knows this, or whether it's part of, my clinical work. And so there's this thing in African-American community, I'm sure it's in other communities as well. Camelia and I have joked about this. I call it, and a lot of people call it, black geography. So when you meet families and when you meet new people, people start to try to place you. right? And in many black communities, especially in the South, I'm from southeastern Virginia, the first question people ask is, where are you from? The second one is, who are your people? And the third one is, what church do you go to? Right? And so it's a way of placing you. And often, you know, in this big metropolitan area, when I meet people, I won't say what church I go to because people are less familiar with my black Catholic church. I will say that my spouse is Baptist. I will say the church, and we go to both. I will say his, and immediately, right, their face will, and they say, oh, yeah, I know Mount Olive, that's Pastor so-and-so. And that gets the conversation going. And so often I can then get into an additional conversation, because they know what I do, about this crosswalk between religion and spirituality and seeking care. And so one of the things I will say often in presentations is, you know, there's this saying in black Protestant faith, faith without works is dead. I will say to people things like, you know, I'm not trying to convince you to do anything you're not prepared to do. But one of the things that I think is valuable to understand is that, I'm just going to use the terminology because this is how I talk with families. And I see the other questions about LGBTQ folks. You have a spirit of love in your family. You have a spirit of support in your family. You have a spirit of empowerment in your family. If there are things external to you that can help you grow that spirit, wouldn't you want to take advantage of those things? Or for parents, your baby is suffering. If your baby had a broken leg, wouldn't you take your baby to the physician to get the leg set, the orthopedist to set the leg? Okay, then we want you to think about mental illness and mental health in the same way. There's a part of your child that is hurting, and all we want to do is help you move to a space. You don't have to stay forever. You don't have to tell people that I tell my black families this all the time, you don't have to tell people that you're coming to see me, but you should come. Or I will say, just go once. Go once and see how it goes. But when you send them that one time, please make sure they get with somebody, you know, who has the best opportunity and best chance to be helpful to them so they don't get turned off to the process. So those are some of the things that I do. So two other questions that I see are, how do you determine or distinguish between mental illness and learned behavior? Often it is difficult because they're so intertwined, right? And so, you know, how I'm diagnosing is I'm using that manual, the Diagnostic and Statistical Manual of Mental Disorders, but I'm also using my knowledge, my cultural knowledge, my training, and my lived experience. And so it is possible that, you know, there's nature versus nurture. So many of our mental illnesses have a hereditary component. So if Big Mama had depression and it was seasonal, right? Every year around Thanksgiving, she would kind of go into that old movie Soul Food. She would go in that back room and she would stay back there and wouldn't come out. And then in the springtime, she would be more engaging. Well, if your family has never talked about that as seasonal depression, then you don't necessarily know that that's what the struggle is. And so for a child growing up seeing that, they begin to think that's adaptive. They think that that is adaptive behavior and don't understand that there may be aspects of that are maladaptive. So I would say I think it's both. And what you're wanting to do to create the distinction or to understand the distinction is to gather as much information as you can. I'm all about data. And then checking that against resources that can inform you and help you understand if it's a mental illness that you're dealing with or if it's learned behavior or if it's both. So I'm going to jump to this question about faith communities and LGBTQ folks. We did not ask those questions as a part of we should have, but we didn't ask those questions as a part of the work that we did. I will say that the way that we tried to incorporate it is I tried to always talk about black people and other people of color in marginalized populations and tried to be careful in my language to say that, you know, you can be black, but all black folks' experiences are not the same, right? So for our brothers and sisters who are of the LGBTQ community, there are aspects of their experience that heterosexual folks or gender-conforming folks are not going to understand, and that our goal was to make sure that there was space at the table for everybody. So I think we tried to do a good job of setting the stage of inclusivity, but we did not directly address those questions. And I will say personally and professionally, my experience is that it's a mixed bag, that there are faith communities that are very open and welcoming, you know this, and there are other communities that are not quite so opening about these, they're not issues, but about members of, our brothers and sisters who are non-gender conforming, LGBTQ, and queer. So it definitely is a mixed bag in terms of experiences. Okay. Let me see if I'm missing any questions. Oh, I see some of my friends here. Dr. Pender Amaker, she's awesome. I love her. I'm so glad that you all are here. All right, let me make sure I'm not missing any questions. Okay. Oh, okay, someone's sharing about they train pastors in talking about mental health. Okay, mental health first aid. Yep. So our work is I think this is wonderful, that in our work we don't train, of course, you're welcome for the response. We don't train pastors to deliver care, or we haven't trained pastors using the mental health first aid method. I actually was part of the team that helped evaluate that for cultural relevance. What I can say is that my community partners who have taken part in it themselves love it, especially my one, she's like a sister, who lost her son. She participated in mental health first aid, and she loved it. She thinks it should be everywhere. But what we do engage in through our work is collaborating, as I shared, with pastors. One of the pastors was a co-PI on the first iteration of the Pipeline Award. We do work with them to ensure that what we're doing, they can take it, and incorporate it in a way that feels relevant for them. So I think the distinction I'm trying to make is I don't feel qualified to speak from the perspective of the Bible stories that talk about mental illness, but we have colleagues who do feel qualified to do that and who do engage in that work. So there's one sister from George Washington University, and whose name I'm blanking on, I can see her face. She is a clinical psychologist and a minister. And so in her church up here in the Northern Virginia area, actually her church is in Maryland, she actually does that work. She has multiple sermons that she and her husband lead. They co-pastor the church, where they will talk about Bible stories, and they will use Bible stories to explain mental illness. So I think, Ms. Beavers, that's a wonderful way to reach a wide range of people with a wide range of needs in a super culturally responsive way. So did I miss any of the questions? I think so. Mm-hmm. All right. Okay, so I don't see any more questions. We have about 15 minutes left. I don't know if you all wanted some closing thoughts or anything. Doctor or Tiara?
Sure. Yeah.
Yeah. Mm-hmm.
No, I don't have any. I think this was an excellent discussion and presentation. I want to thank Dr. Alfiee and Camelia for joining us today and giving us this extra time to answer all of the questions. We've had a lot of great participation from the audience, so really thankful for everyone that's attended. It's a great group. If there aren't any other questions, I just want to encourage folks to please take the survey. Tiara has shared the link on the public chat, and and I will just wait another minute. I see some typing, but if there are okay, they're just chatting. So if there are no other
information, which is good. I'm sorry. Go ahead.
No, this is great. So this is really, I'm really happy to see the chat, because sometimes we don't get as much feedback on the chat. So thank you very much for the participation, everyone. And again, thank you, Dr. Alfiee and Camelia, for a wonderful presentation. We encourage you to download the PowerPoint, and you'll also be getting a notice about the recording. Anyone have any parting thoughts? Thank you.
Thank you all so much. I hope everybody has a good rest of the day, and take care of yourself. Bye-bye.
Bye-bye. Thank you.
All right.